Thank you. I'm going to start out, Dr. Vigo. Police buy-in was a key aspect of the government's justification of launching the decriminalization pilot that made hard drugs legal in British Columbia. Last week, both the BC Association of Chiefs of Police and the Canadian Association of Chiefs of Police pulled their support. They cited a continued high rate of overdose deaths, public drug use, and drug-related crime since the pilot had started. Have you or will you advise the government to end the failed experiment?
Thank you, Ms. Goodrich. The recommendations that I have provided are aligned with what we are doing now in BC, which is that the use of drugs itself should never be criminalized. However, in our societies, we have rules and regulations that should be respected by every citizen. And in that context, the current situation is that drugs are not criminalized, but the rest of the rules that regulate our interactions are enforced.
Okay, so you will not give recommendation to roll back this irresponsible pilot project?
So, coming back to my expertise, which is psychiatry, mental health, and public health, what I can say is that drug users should not be criminalized, and the laws that regulate the public space.
All right, thank you.
The safety.
I have very limited time. I'm going to switch courses.
We have limited time, but I'm a witness.
I gave you the same amount of time as I asked the question, which is the procedure here in this committee. To Ms. Brett, thank you so much for coming here and sharing your son's journey and your experience as a mother. Do you think the NDP Liberals have normalized drug use in this country?
Yes, I do.
We had a mother from Ottawa come and testify at this committee that government is acting like a drug lord. Do you agree?
In essence, it's true. I saw her testimony. Yes, it's coming from the top down. The federal government has arranged laws to support safe supply, which has been delivered to clients who divert, and young children are dying as a result. It's drug trafficking.
So, in your opinion, do you think that this dangerous pilot project that was inflicted on British Columbia should continue?
Absolutely not. The moment that one child is impacted, in any negative way, this should have been stopped. This is, a lot of the folks who come to this panel have used the word dignity and respect, but I claim that there is a moral and ethical obligation on the part of the government to respect human life and that of innocence. The children who find themselves intercepting with diverted drugs is the beginning of the end. It must come to an end.
No, I really appreciate this. And I think this is the scary part, is the government keeps hearing evidence and evidence they don't like, and so they decide that it's not actually evidence and that they're going to continue on their path because clearly we just haven't done it properly. Dr. Knight, I found it really interesting. You said that the outcomes are poor in Oregon and British Columbia, but you think that we should continue trying to do what has been a failed experiment. But then further in your statement, you actually stated that Alberta, which is doing some dramatically different recovery-oriented system of care changes, that the Alberta model, the potential person that you were fabricated in your story, that would be a better outcome. So how can both things be true? I'm very confused.
So I think intentionally or unintentionally, you've taken my comments out of context. The thing that I compared between Alberta and Manitoba is a difference in provincial correctional policy related to opioid agonist therapy. I did not speak specifically about Alberta's model of care.
Okay, thanks. So you support Alberta's use of opiate agonist therapies. I'm sure you're aware Alberta has a very innovative program that's the virtual opioid dependency program that allows 24/7 access to opiate agonist therapies. Is that something that you think we should be rolling out across the country?
I think there are elements of the VODP program that are very successful. I think that there are also elements that don't reach at-risk populations, and that it is one thing as part of a multifaceted expansion of service that we could look at. I do have concerns that it is entirely virtual, and there is some need to see people in person and to develop relationships with people. Really quickly,
You mentioned one of the things that I think is a failure from Health Canada on the lack of listing of injectable naltrexone. I have advocated to ministers of health and ministers of mental health and addiction on this particular issue, and it's fallen on deaf ears. So you now have a platform. Why do you think this is important?
It's important to expand the availability of evidence-based treatment options. Right now we have accessible, our first-line treatment options. We have also in certain areas.
Specifically naltrexone, because this is something that is not available currently.
It's something that is not available currently, and that we as addiction physicians have been advocating for availability for many years. There are some barriers that have been put in place through Health Canada, and we are asking for support of the federal government to decrease those barriers so that we can have this option for treatment.
Thank you, Dr. Knight. Thank you.
Thank you, Mr. Chair, and thank you to all the witnesses who have appeared. Ms. Brett, thank you for your personal testimony here today, as well as sharing the story of your son, Jordan, and very happy to hear about his 1 year of sobriety, and you certainly have added value to the meeting we're having here today. Unfortunately, we now have a number of years data to go back on, and we see that what's the current approach is simply a proven failure. It's not working. In 2016, Canada had about 7 overdose deaths per day, which is a terrible stat, except when you compare it to now that stat exceeding 21 per day, or an over tripling of the number of deaths. So we look at, okay, what actions have taken place, and one of those actions that this government brought in was it was in a bill called Bill C-5, and what it did, it eliminated mandatory jail time for serious criminals who were producing and importing drugs like fentanyl, meth, cocaine, etc. The most serious, or what is called Schedule I drugs in Canada. What it allows these individuals to do is to import those drugs, export those drugs, or produce those drugs, such as running a meth lab out of their own home. But then if they are caught by the police and charged and then sentenced, they can serve their sentence from the comfort of their own home. And I think that sends a terrible message to Canadians and allows for the re-victimization of the most vulnerable. But I want to get your thoughts on that. In your opinion, should those that are bringing deadly drugs like fentanyl and meth into Canadian communities face more serious consequences?
Absolutely. It's shocking how vulnerable, homeless, mentally ill, and addicted people are. My son was, the constant victim of violence. He was never safe. And the great irony of the baffle gab and, the buzzwords like harm reduction is that while he was out on the street, decades worth of living outside, he was predated by other addicts, by dealers. He had a knife held to his throat for a $2 drug debt. He was routinely threatened. Someone in my presence said to my son, we'd break your legs for that. I mean, what? So we need to support police. We need to give them all the tools that they can, and Bill C-5 should be repealed. We need drug dealers, drug creators to face the stiffest penalties. Our children are dying, and they're dying under horrific circumstances predated upon.
Thank you for that. You said something that I took note of. You said stigma does not kill, but drugs do, and there's certainly no doubt that that drugs are taking the lives of so many, and it is an epidemic, and that's why we're having these meetings now. We're looking for solutions. You've been very critical of the buzzwords, and you are saying we need to focus on things that actually work, actual results. Can you expand a bit on your statement about that it's not the stigma, but that it's the drugs that are taking innocent lives?
Sure. My son was in treatment 26 times. He entered 26 different treatment facilities, and in almost every case, he was kicked out. He had an undiagnosed mental illness, and this was some of the evidence. He also attended about 5,000 AA and NA meetings while he was drunk, while he was high, while he was sober. He has always had an intention to not use drugs, and yet we claim that the stigma is so overwhelming that these people need the succor of drug injection sites and safety. And this is a man who knew his mind when it came to drug use. He did not want to be and does not wish to be a user, and Safe Supply is an expensive PR campaign to promote a false narrative that these are individuals who want and need to sustain their drug use. He wanted off, and he has arrived at that moment. He is a year clean, and this is evidence that involuntary care and clozapine in combination do miracles.
Thank you, Ms. Brett.
Thank you.
Thank you, Mr. Chair. Thank you to our witnesses for being here. Dr. Vigo, you've just in your answer to our colleague Gord Johns, you stated some statistics and some facts. Are you able to table that document or that information with our committee, please?
Yes.
Thank you. Ms. Brett, in your opinion, does Canada prioritize recovery for those with substance use issues?
No, not at all. My son has lived through hell, gone through hell, as have I and my family. He's been essentially victimized by the lack of appropriate care. We've pounded on every door, and yet in the end, his behavior became, he turned into an animal. I found him bent over, eyes closed, unaware that he had his eyes closed when speaking to me, and there was just never any supportive help. Not what we needed when we needed it. It's chaos. It's malevolence to leave people to die on the street. It's malevolence. It's a form of evil. It's inhumanity. It's man's inhumanity to man, and we need to do everything we can to change this. We are in an emergency. There is no doubt. We must act as if this is a crisis of immense, horrific proportions.
You said that in your opening statement you've been in New West since 1994. I'm sure that over the course of those years, you've seen changes to our community and to the New West community due to the drug crisis.
Yes, there was chaos on the streets. It was reported by everyone. Violent acts. We had a carjacking. A taxi jacking, which resulted in multiple car crashes. In Vancouver, of course, we had someone who cut off the hand of an innocent bystander. The chaos has just continue to mount and deaths continue to mount, we cannot, in good conscience, any one of us, continue the status quo. It cannot remain thus.
Would mandatory treatment have helped your son get clean? Has it helped to get him clean? He's a year sober.
Yes, he is a year sober. He has been under the Mental Health Act involuntarily. This is the end of year 4. So it's been a process. He did use occasionally in that window prior to this last year, and but there has been such an amazing focus of care, limitation of movement, locked facilities were the ticket to begin with, and continue to be where needed and when needed. And he is a miracle of the benefits of mental health care, the best psychotic drugs like clozapine, great therapeutic services provided by the psychiatrist there. We couldn't be happier. This is a godsend. It's a miracle. We need more, and we need it now.
Ms. Brett, if you could speak directly to Prime Minister Trudeau, Health Minister Holland, and the Minister of Addictions, Minister Sachs, right now, what message would you give them?
Oh, dear God, do not prevent the opportunity for our children to have this care. They need it so desperately. They are dying every day, every minute. I'm so sorry. We need the floodgates to open. We need help. We can't live this way. Oh, we can't live this way. Thank you. Oh. Sorry.
I truly appreciate your heartfelt testimony, as you probably have heard. My brother's on the street as well too, has been since the early 90s. Might even have he started on the streets in Surrey and New West, and so very likely had probably been in the same circles as your son. So my heart goes out to you, and I wish you and your family nothing but the best. Thank you for your testimony.
Thank you, Mr. Dorr.
Dr. Knight, I have a couple of questions for you, if I might. You talked about evidence-based treatment with respect to opioid use disorder, substance use disorder, etc. Can you tell us exactly where the so-called safe supply fits in that? What is the evidence? And if you have some, I think it's important that you table that with the committee.
Thanks for the question. There are some reasons why I deliberately didn't talk about prescribed safer supply in my recommendations, and that is partly because I feel in the reading of the evidence that it exists to date that we don't have a clear picture of the role of prescribed safer supply. I do want to highlight that it really is an intervention that is trying to decrease people's reliance on the illicit toxic drug supply, and that there are other mechanisms to do that as well that could be considered, including what Dr. Vigo talked about in terms of that regulation of drug supply.
So Dr. Knight, if I hear you correctly, and this is your area of specialization, this is what you do, that realistically the use of, as you call it, prescribed safe supply, which I'm not entirely sure how much prescribing is going from some of the testimony we've heard, simply because there doesn't always appear to be a significant doctor-patient therapeutic relationship that exists. That being said, what I heard you say just now is the scientific evidence related to that is minimal. That would also go on then to consider that what we're seeing with this so-called safe supply is an experiment with a terribly vulnerable population. Is that what you see it as? I mean, yes, I agree that perhaps the intent was to save lives, But there's no evidence, and of course you mentioned in one of your statements that it's important we use the best evidence there is.
I'd like to clarify that my position is not that there is no evidence for prescribed safer supply. My position is that there is conflicting evidence. We know that there are some benefits for people who access prescribed safer supply, and we know that there are some potential harms. And so what is not clear is where that balances out in terms of risks and harms. And anytime we do any intervention, that's the question: is the balance of benefits higher than the balance of harms?
So I'll just interrupt you there, Dr. Knight. And, you know, when you look at this, again, you talked about the evidence. I think it's important that the evidence that you cite, that you table it with the committee. Would you undertake to doing that, please?
Yes, I can send some evidence to the committee. Absolutely.
And again, I did talk a bit about this, as we've heard not just today, but multiple times from many witnesses, that this is an extremely vulnerable population. Would you agree to that?
I would agree that lots of people with substance use disorders have aspects of vulnerability. There are lots of people who have substance use disorders who are highly functioning people in our society as well. I go back to the idea that really people...
Sorry, Dr. Knight, I just have limited time. The other question I would say to you is does it make sense then, without their consent, to do experiments, first of all, on anybody, but certainly on vulnerable populations and people who may or may not be impaired by substance use?
I said this earlier in one of my comments. When we're doing scientific research, there are checks and balances in terms of the ethics and in terms of...
Dr. Knight, there was no checks and balances in so-called safe supply. Do you think that folks who were receiving so-called safe supply consented to it being an experiment?
I can't speak to the individual conversations between the prescribers and the people who receive safer supply, but it would be general medical practice to discuss the risks and benefits of any treatment with individuals.
Well, I think, Dr. Knight, we've established already that many folks who receive so-called safe supply didn't even have a doctor-patient relationship with their prescriber. So how could you possibly think that they have any consent to be part of an experiment? Please, I mean, as you're a scientist. I think this is basic science, is it not?
I think, again, we need to go back to the idea that this brings us back to the need for recommendations on a national level in terms of what are the requirements.
But Dr. Knight, this is about a basic science experiment gone wrong.
Thank you. That's your time, Dr. Ellis.
Thanks, sir.